Welcome to the Gerontological Society of America's Momentum Discussion, where we explore the groundbreaking topics and advancements that are generating significant excitement in the field of aging.
Welcome to this GSA Momentum Discussion, facilitating high-quality neurology referrals for individuals with cognitive impairment. GSA Momentum Discussions highlight topics experiencing great momentum in the field of gerontology. My name is Jen Pettis, and I'm the Director of Strategic Alliances at the Gerontological Society of America, or GSA. GSA appreciates ASI's support of this momentum discussion, but I'd like to acknowledge that our moderator and panelists did not receive financial compensation for their participation in the program. It's my pleasure to introduce our panel and moderator for today's momentum discussion. Dr. Michael Hornbecker, the U.S. Fellowship Lead for the Davos Alzheimer's Collaborative Healthcare System Preparedness Program, will moderate today's webinar. Dr. Hornbecker is joined by Dr. Barak Gaster, Professor of Medicine, General Internal Medicine at the University of Washington, and the Director of the Cognition and Primary Care Program. Dr. Justin Moon joins us today. He's the Director of the Denver Neurological Clinic. And our final panelist is Dr. Michael Rosenblum, Associate Professor of Neurology at UW-Medicine and the Director of Clinical Trials at the Memory and Brain Wellness Center and the co-investigator in clinical core at the Alzheimer's Disease Research Center. Thank you all for participating in this program. And Dr. Hornbecker, I'll turn it over to you now.
Thank you, Jen. So just to set the stage a little bit, the Alzheimer's Association in 2024 in their facts and figures reported that there's an estimated 6.9 million Americans 65 and older that are living with Alzheimer's dementia. The association also noted that approximately 12 to 18% of people over the age of 60 are living with mild cognitive impairment, and that about 1/3 of the people living with MCI due to Alzheimer's disease develop dementia within about 5 years. We know that much of the care for people with dementia is managed by primary care providers in this country, but there's still a need for prompt and effective referrals from primary care to neurology when appropriate, especially with the advent of some of these disease-modifying treatments that are somewhat new in the field. These referrals are important to be timely and appropriate, and that sort of sets the stage for our webinar today. We do know, however, that unfortunately many people with Alzheimer's disease and most people with MCI are undiagnosed. In fact, researchers at the University of Southern California reported earlier this year that last year, that only about 8% of folks with MCI have their condition diagnosed. So with that, Barak, we're going to start with you, Dr. Gaster. What are some barriers to early diagnosis of Alzheimer's disease and MCI, and how can primary care teams overcome those barriers?
Yeah, obviously, anytime you're talking about primary care, the number one problem is time. Primary care is always juggling 15 different problems, and there's so much, I think, pressure that the systems put on primary care and that primary care providers put on themselves to try to take care of everything at every visit. And that is really challenging, especially with what can be a time-consuming process of evaluating somebody's cognition and making a diagnosis of, say, mild cognitive impairment. And so I think the number one pearl that I share as part of our training, and that I know that you, Mike, and the great work that you're doing as well, is really to focus on the dedicated visit to do a cognitive evaluation, that rather than trying to evaluate cognition and evaluate somebody's knee pain and take care of their hypertension all at one visit, you really set aside a specific dedicated visit that is just for doing a cognitive evaluation, and that you try real hard to have a close friend, a family member, an observer, an informant come to that visit as well as a really important part of the evaluation.
Thank you. Thanks very much. So, Justin, can you provide some insights into which people with Alzheimer's disease or MCI the primary care team should prioritize for a referral to neurology, and why those people specifically should be prioritized?
Yes, we're looking for people at the early stages of disease. Most often in a neurology office, traditionally, we would see those patients well in advanced stages of disease. That is where you have a holiday, a family gathering, and then someone speaks up and says, there's something wrong with mom, okay? Oftentimes, patients have some self-identification of issues, and they may casually come to their primary care provider and say, hey, I've been having some memory problems. And so it's very important for all medical professionals to take those patients seriously. Now, let's say you're in your 50s and you say, I'm forgetting a few things. And oftentimes we do the basic workup, B12, thyroid, we check about sleep, pain, medications. And these are all important variables that we want to exclude out as factors. But even past that, it's always worthwhile to do a memory test and then to listen to the patient. For instance, if they say something key, it may change your opinion about a case. For instance, if your husband forgets your second cousin's spouse's name, it might not be a big deal. If they forget their favorite grandchild's name or their birthday, that might be a bigger deal. If they can't remember how to get to their adult child's house when they've been driving there for years, those things are flags to say this is very unique and unusual and different from the baseline. And then that would warrant an investigation. So we want to identify those patients at early stages of disease because now we can do investigations and perhaps have therapies for those patients.
Great, thank you. Dr. Rosenblum, can you tell us, Justin in the last question mentioned some of those therapies, those especially newer therapies. Can you tell us a little bit about some of these new therapies, these disease-modifying treatments, and who may benefit from them and should be prioritized for neurology referrals?
Absolutely. So this is a relatively new class of drug that's available for patients with Alzheimer's disease. And they work by binding as antibodies that stick specifically to amyloid in the brain. And then they remove the amyloid from the brain through an inflammatory pathway. And there's two drugs that have been FDA approved. One is known as lecanemab. Another one is known as donanemab. And then before that, there was a drug known as aducanumab, which unfortunately was not found to be reliably effective and safe, so it's no longer on the market. Now, these drugs work based on the amyloid cascade hypothesis, and this is a theory that has been around for decades that talks about how amyloid deposition in the brain is one of the earliest signs of this disease. In fact, it's thought to occur decades before patients present to their doctor's office with memory symptoms. So you can think of this process as consisting of three different stages. One is the misfolding and accumulation of amyloid or amyloidosis phase. And then after that, there is development of neurofibrillary tangles, which is the other pathological entity in addition to amyloid that is found in the brains of persons with Alzheimer's disease. And then finally, there's this third stage where there is inflammation, development of oxidative free radicals, neuronal cell death. And these drugs, in theory, are supposed to interfere with this cascade at the first phase where there's amyloid accumulation. And through doing that, potentially there is a disease-modifying effect.
Great. Thank you very much. So I want to get to talking a little bit about what, primary care teams can do to identify those folks who might benefit from some of these therapies and prepare them or tee up, if you will, the referral to neurology. But before we do that, and I know, Dr. Rosen, we touched on this a little bit, but Justin, can you tell us a little bit more about exactly how these anti-amyloid therapies work?
Yes. Not only do they clear the amyloid plaque itself, but it may also work on the precursors to the plaque, removing some of these proteins that are causing dysfunction even before the plaque forms. And so these are very unique mechanisms. And to give you a personal perspective here, this week, we had two of our patients 18 months on the first medication, lecanemab therapy. And they have completed our kind of wrap-up evaluation, which includes repeated neuropsych evaluation, PET scan, and serum biomarkers. On the PET scan, these two patients showed no further evidence of plaque. Okay, now, this is not a promise for all patients But even in the clinical trials, we see that we can reduce the amount of plaque. When we checked the blood biomarkers, there was no evidence of abnormality on the A beta 42, the P181, or the P217. Basically, it looked like a normal patient. And then finally, on the neuropsychological test, there was still some decline on these individuals. But in one of the individuals, their verbal memory actually was slightly better than the testing that they performed 18 months earlier. So this is to say that the therapies we know do work with this type of mechanism in terms of removing plaque and reducing some of these proteins. It doesn't necessarily reverse memory per se, but the idea here is to slow down the disease state and the disease process.
Great. Thank you. Thank you very much. And then Dr. Rosenblum, I think it's exciting to talk about these new therapies, obviously, but one of the things we all have to consider, and especially in primary care, I know having come from that space, we think a lot about safety for our patients. And then, of course, how to talk about these drugs as far as efficacy as well. So could you talk to us a little bit about the safety and efficacy of these disease-modifying therapies?
Absolutely. And I'll start by piggybacking off of what Dr. Moon just described with his patient. He talked about a patient who had clearance of the amyloid plaque buildup in the brain. And that's pretty profound and obvious when you compare the scans to the baseline amyloid PET imaging. But the clinical impact, the impact on cognitive and functional decline, that impact is to a lesser degree. And so there's this disconnect between the removal efficacy in terms of removal of amyloid plaque and the actual clinical outcomes. And the drugs that I mentioned earlier, lecanemab and donanemab, if you compare these patients to the average Alzheimer's patient who does not get any such treatment, you'll see that there's about 27 to 30% slowing of cognitive and functional decline in those individuals receiving these monoclonal antibody therapies. And so if you try to talk to a patient and say, what does this mean in terms of the slowing of decline over an 18-month period, that is similar to about 4 to 7 months of slowing relative to someone who did not receive the treatment. So you buy yourself more time. So if you have a patient who's in the mild cognitive impairment stages of Alzheimer's disease, they're going to spend more time within those stages before progressing to mild dementia. Now, that being said, these benefits are relatively modest, but they're certainly findings that are quite significant and were never found in clinical trials up to this point. So that has caused a bit of excitement for those of us who are specialists in behavioral neurology. It should be noted that these drugs are not completely safe, and they do have more side effects than the drugs that we're used to prescribing, such as donepezil and memantine. So, for instance, these drugs are given as infusion therapies, and so about 26% of patients who receive lecanemab experience an infusion reaction, which is essentially an immune overactivity. Patients may get fever, chills, muscle ache, but these are symptoms that are readily treatable by the infusion nursing team. And at least at University of Washington, we have had minimal problems with the infusion reactions. They're usually self-limiting. The other side effect that gives prescribing physicians a little bit more heartburn is the amyloid-related imaging abnormalities, or ARIA. And you can see this as a byproduct of the mechanism of action of monoclonal antibodies, which bind to the precursors of the amyloid plaque, and then through an inflammatory reaction, lead to the clearance of these abnormal proteins. And this involves activation of the microglia, inflammatory cells that are found within the central nervous system. This leads to localized inflammation that can cause the blood vessels to become more leaky. And you have this localized swelling known as ARIA-E for edema, so brain swelling. And then the other manifestation is ARIA-H, or microhemorrhages. And you can see these microhemorrhages on specific sequences using MRI. And often ARIA-E and ARIA-H, they occur together. For instance, if you were to give a drug like lecanemab, the risk of having ARIA-E or ARIA-8. This is something that you can see fairly commonly in over 30% of patients combined. And then if you were to see this in donanemab, there's actually an increase, a higher risk of ARIA. And there have been modified titration schedules that have been developed that will help limit the ARIA side effects associated with donanemab. But these are still risks that all clinicians have to be aware of. As a result, there is what's known as surveillance MRI imaging, where there are MRIs that are performed at certain times. You get about 4 surveillance MRIs for each of these treatments, whether it be donanemab or lecanemab, to look for any of the swelling or microhemorrhages in the brain. It should be noted that the majority of patients who present with ARIA are asymptomatic, and only in fewer than 1% of the cases is the ARIA life-threatening or leading to a hospitalization.
Great, thank you. So certainly a lot to consider. With that in mind, I want to take a step back and come back to you, Barak, from the primary care perspective. Obviously, one of the reasons to make a referral to neurology in these exciting times would be that a patient may be a candidate for these treatments, but that's certainly not the only reason. So my question is a two-parter for you. One, when do you decide to make a referral to neurology, and what are those situations where you feel like the neurologist and that referral is warranted? And then two, what do you do to get your patients ready, if you will, tests that you might order, that sort of thing, for that neurology appointment?
Yeah, so much of that is obviously limited by the fact that there's often a really long wait time to get in to see a neurologist. And a lot of the conversation has to be a shared decision-making conversation with patients and families. And I think I'm very attuned, alert to like big red flag issues that should prompt me to want to refer somebody right away. So somebody who's having rapidly progressive symptoms, like certainly anybody who is developing cognitive impairment before the age of 65 really should get in to see a neurologist right away. People who are having visual hallucinations, where that really might be a harbinger for Lewy body disease, which is a much harder diagnosis to make, that you really do want to have a specialist involved in right away. But mostly you're going to talk to patients and families in just a real world and transparent way that there are drugs that might help. And if those are drugs that you might be interested in learning more about, then we should definitely try to get you in to see a neurologist as soon as we can. There's just so many things that we should be doing in primary care that really, I think, help neurologists so much as well, which is really just to think about having a primary care checklist for cognitive impairment that really includes things like not forgetting to ask, how much alcohol do you drink? I think that probably the number one overlooked factor that is impairing cognition in people over age 65 are people who are drinking 3 or 4 or more drinks a day in a way that may not have exactly qualified for them to have a diagnosis of alcohol use disorder earlier in their life, because it was maybe half a bottle of wine or even a whole bottle of wine that was not interfering with their functional sort of day-to-day life. But that now that they are over age 65 and they are concerned about their cognition, really that is a level of alcohol where you can be pretty confident that telling them to reduce that alcohol intake is going to improve how well their brain works. And then also, just probably the second most overlooked question is, what over-the-counter medications are they taking? Because it's somewhat easy to keep your eye on anticholinergic medications that you might be prescribing to somebody, like oxybutynin, that might be affecting their cognition. But so many people out there are taking over-the-counter sleeping aids that have diphenhydramine in them, brand names like Tylenol PM, where people feel like they're doing good things for their brain by getting more hours of sleep, because that's so much in the news these days. But in actuality, those anticholinergic medications for sleep, like the active ingredient in Tylenol PM, can be enormously harmful to cognition in people over age 65. And so those are the checklist questions that are really important for primary care to be asking. And then there's like the lab tests are relatively easy and straightforward, but are silly to miss them. So B12 deficiency or hypothyroidism, TSH and B12 are such easy blood tests to do, and really should be a pain in anybody who you're worried about cognition.
Great, thank you. So Michael, we just heard from Barak. He talked about some of those, obviously those sort of bread and butter tests that we would do prior to a referral, and some of those important questions to ask and medications to review. But when you have a patient sort of sitting in front of you that's been referred from primary care, what are some of the other tests that might be indicated in those patients? And then specifically related to the topic of disease-modifying therapies, are there special tests that might be required for those patients that you're considering for those therapies?
Yeah, sure. Traditionally, when we evaluate patients for memory loss, we're often checking the labs that may contribute to cognitive problems. Common things we see in the elderly, like having B12 deficiencies or thyroid abnormalities. So those labs are certainly important to check before patients see us. Also, making sure that patients don't have any problems with their electrolyte, a metabolic panel is helpful. And then some type of imaging study is important. And the MRI is critical not only in the diagnostic process of trying to land a diagnosis of Alzheimer's disease, but also it provides that baseline information to gauge the risk and benefit of giving a monoclonal antibodies. For instance, patients who've had prior bleeds in the brain, or they have a significant number of microhemorrhages that may indicate an underlying dosis of amyloid angiopathy, or if they've had recent strokes. These are all factors that would make giving a monoclonal antibody more risky. And so as a result, it's helpful to have that MRI to really understand whether or not you're doing the right thing for the patient. In addition, the cognitive screening tests that can be done in primary care, like the Montreal Cognitive Assessment or the Mini Mental Status Exam, this gives us an idea of where the patient is at in the continuum of Alzheimer's disease. Based on the appropriate use criteria, patients who have mini mental statuses of 22 and above and a MoCA of 17 and above, these are the patients who are more likely to benefit from the monoclonal antibodies and were studied in the Clarity AD clinical trial with lecanemab. And we're using the cognitive screening to say, all right, well, fine, do we or do we not have a patient who could benefit from this intervention? And if they're below those cutoffs, then, they're more likely to be in the moderate to severe stages of disease, and there's no evidence that these patients benefit. The other thing that has changed over time is that these patients need to have some type of biomarker evidence for Alzheimer's disease. And this is, again, something that is described in the drug label and the appropriate use paper published by Cummings and colleagues. FDA-approved biomarker studies include doing a spinal tap for a panel that includes A-beta 42, phospho-tau 181, and total tau. In addition, amyloid PET imaging, which is the type of scan where a ligand that binds specifically to amyloid plaques in the brain is used to show whether or not these plaques are indeed present in a given patient. And if they're positive, then these patients are appropriate to receive lecanemab and other monoclonal antibodies. So having one of those two FDA-approved studies, it's recommended. There has been some work looking at blood-based plasma biomarkers like p-tau217. And this is something that we may see evolve over time because a blood test is much easier than doing an amyloid PET scan or a spinal tap for fluid analysis. Finally, it's important to look at what's known as 4. This is a type of genotype that incurs an increased risk for Alzheimer's disease. You can have up to 2 copies of this genotype. And we know that whether or not you're a carrier of 1 versus 2 alleles for ApoE4, you will incrementally increase the risk of the amyloid-related imaging abnormalities that I discussed previously. What we like to do, at least in our clinic, is have the ApoE genotyping performed so you can risk stratify patients, and then you have a better understanding of the risk-benefit ratio. And so if someone is homozygous for E4, they have up to a 45% risk of ARIA with lecanemab, and you may want to defer on treatment in that patient population. So these are all studies that help you, number one, understand the disease and confirm that you're truly dealing with Alzheimer's disease, but also assist you with medical decision-making in weighing risk versus benefit.
Great. Thank you. Justin, Dr. Moon, I would just ask for you to provide me additional insights you might have about in regard to the imaging and other diagnostic tests that are necessary prior to prescribing these medications, and then maybe also comment on how you might follow those over time a bit.
Yes. So it's important for all providers to understand that this is a continuum of evaluations. And what we're trying to get is the gestalt. There's not a single identifying test that is going to be 100% accurate and give you that diagnosis. And so what you want to do is you want to work between your primary care providers and your neurologists in the community. In some areas, you might be able to get in early and the neurologist would prefer to do the workup themselves. In other areas where there might be a longer wait, it might be important for the primary care doctor to initiate some of the workup before they are actually seen by the neurologist to help facilitate this process. When one of the early things that we do is order the MRI and understand that MRIs, our radiology colleagues are flipping through multiple MRIs per hour. And unless they get a clear understanding of what they're looking for, and unless they're really focused on identifying the variables that we are looking for in dementia and Alzheimer's disease, you might get a very bland report. You might say normal MRI, just because there's not a tumor or there's not a stroke on that image. But getting that MRI is important for us as neurologists downstream to review it ourselves and put our own mark on how we view this image. Other things that have come along, and as you heard earlier about checking blood biomarkers, and then there's even a skin biopsy now out. So as we develop more tests, these could be intermediary tests to help narrow the field in cases where we're not certain. We're not certain if we want to send for a lumbar puncture or a PET scan, and you might want to get this intermediary test to help guide you along this process. So this is still evolving and is very important. But as you heard from me earlier, we do these tests at the beginning prior to treatment, and then now we're doing them at the end of treatment to see how the patients have progressed. For our knowledge, to show the patients what has taken place. And it's very important for us to follow up on some of these tests. You might get a borderline evaluation. You might get a blood biomarker that's right on the line, or CSF study that maybe one of the markers is abnormal, but not the others. So what do you do with that information? Can you go to an additional test like the PET scan, a skin biopsy, or do you wait and follow these tests? And these are things that we are all still working through now in terms of identifying best practices.
Thank you. Dr. Rosenblum, to come back to you, when you have a patient in front of you and you think they may be a candidate for one of these therapies, how do you talk to that patient? What considerations are you thinking about in your head? And then how do you communicate that with the patient when you're approaching the subject of maybe going on one of these new therapies?
Yeah, I think it's really important to be neutral, be like Switzerland, try and just present the fact. And these drugs are unique in that they were found to have statistical significance. The clinical significance is still something that has been debatable with various experts in the field. And so it's important that patients appreciate that these drugs are not magic bullet, but they are designed to be disease modifying, that they're not going to necessarily improve cognition and function, but their role is to maintain. And we also know that maintenance is 80%, but it's closer to 27 to 30% in terms of slowing. I do mention that in terms of the benefits of the drug. It's important that patients appreciate that there are various drawbacks, like the drug is given as an infusion. And depending on whether you choose lecanemab or donanemab, that you may be committing yourself to infusions every 2 weeks to every 4 weeks. And the other thing is that these trials have gone on for about 18 months. There may be a need to treat patients beyond the 18 months. And again, you're tied to an infusion center, at least with the way these drugs are given now. Patients need to figure out if the distance is worth it for them. A lot of our patients are coming from rural Washington to get to us here in Seattle. We also talk about the potential adverse side effects, and that involves the infusion-related reactions that affect about a quarter of patients and the amyloid-related imaging abnormalities that I mentioned before. And it's not a large number, but patients should know that about 3 individuals in each of these studies died from taking these drugs. And so that's important to know as well. We have a information website that includes a webinar that we delivered for the community, as well as links to various publications to help patients with their decision-making process. And it's also really important for me as a clinician to ensure that the patients understand what they're getting into and they're not being talked into something that they don't truly understand. And that's something that's really important to me as well. And of course, we talk about variables like the ApoE4 genotype that may influence one's risk for some of the ARIA side effects. So those are the elements that go into a discussion when we talk about giving the monoclonal antibodies to these patients.
Great, thank you. And then, Justin, again, I come from the primary care world, and from a primary care perspective, as Barack said at the beginning of this webinar, you're asked to deal with the back pain, the knee pain, the runny nose, and by the way, I'm having some memory problems. And I think these new therapies they're complicated. There are real side effects involved, and they deserve quite a bit of consideration. But if you were giving advice to your primary care colleagues about how to talk to patients and approach this subject with them, what would your advice to them be, how to talk to their patients about these therapies?
Sure. I think the advice would be to understand the basics, some of the nuts and bolts of what we're talking about, how the therapies work, what the potential side effects are. Just have a broad understanding. You might not have a comprehensive opinion as of yet. Many doctors don't without experience, but have broad understanding of how these drugs work. And then work with specialists in the community who actually have experience, who've actually done it. Talk with them about their experience, and then refer your patients to those individuals who can go into more detail and give that patient a little bit more firsthand experience of what they're seeing in their patients. And then again, it gets back down to identify these patients early. Identify them, talk to them, and see what they want to do. And I like this idea of being very neutral in your approach. If your primary care doctor has hesitancy with one of these therapies, basically it's not going to move past that. That patient is not going to seek that specialty opinion. Whereas if you present the facts and give them the options, you can at least let them decide on how much further they want to go with the evaluation and potential treatment.
Great, thank you. Brock, I'm going to come back to you for the final word here, because I think we're nearing the end of the webinar. But we talked a lot today about neurology referrals, realizing that's not the only referral that you might make for a patient with dementia. So I'm going to ask you, again, the two-parter. So first, what other specialists might you refer a patient to that has dementia? And then I think lastly, or the second part of the question would be, how do you, as a primary care physician who's doing this, if patients come in and they're asking about some of these new therapies, or you think they might be a candidate for one of them, how do you talk to them about them? So the two-parter.
Yeah, so the question of other referrals is really important. I think probably the number one referral that I feel great about making is to audiology. I think a hugely overlooked connection exists between hearing loss and cognitive impairment, and it's really always tricky to know, is it the chicken or the egg? Is it the hearing loss that's causing the cognitive impairment, or is the cognitive impairment causing the hearing loss? But for sure, anybody over age 65 who is concerned or having trouble with cognition really should get their hearing checked. And it's easier said than done to actually get people to wear their hearing aids. But I think making that connection between hearing and brain health is a really important thing to do in primary care and can make a big difference. I think the next sort of referral that I really try to have foremost in my mind is occupational therapy. And again, that so much better if the occupational therapist is able to get out to the home, which can be a challenge in terms of coverage. Like you need somebody to be functionally homebound for Medicare to pay for an occupational therapist to go out to the home. So if your patient is advanced enough, that is a option, then that is a really important thing to help to set the home up to be as safe and good for somebody with cognitive impairment as possible. But even if somebody is not so advanced that they are functionally homebound and that they're doing an in-clinic occupational therapy assessment, that's still a really valuable and good opportunity to really help people to look at how are they functioning with their activities of daily living and what changes could be made to help them remain as independent or as they can for as long as possible. And then I think the other surprising field that can really offer a lot to people with cognitive impairment is speech therapy. And I can tell you, as I was becoming a dementia expert, that was always like a surprise to me because my memory of speech therapy is, can they swallow safely? And that's how we all, I think, learned to use our speech therapy colleagues. But there are a growing number of speech therapists who really do focus and specialize in cognitive impairment and can really help a patient and family a lot in terms of communication strategies to help people to stay as functional and independent as possible. And then probably like the fourth referral that I really try to in my list is an attorney who has expertise in elder law, just because it is often really complicated for a patient and family to navigate through. How do they deal with their finances? How do they deal with all of the assets issues that they may be facing soon that are certainly way out of the wheelhouse of primary care and probably even outside the wheelhouse of a social worker if you are lucky to have access to one, where you really do want to encourage people to get legal advice from an attorney who specializes in this area.
Great. Thank you. I want to thank you all for taking the time for joining me today for this webinar and sharing your thoughts around this very important topic. Any final thoughts? I'll just go around the panel, starting just by my Zoom view here with you, Justin, in the top left, if you will. Any final thoughts for our viewers today?
Yes, I think this is a very exciting time for us in neuroscience, and it should be an exciting time for all of us in medicine as we're opening an area that we really had given up on, that we thought was dead from a clinical perspective. And as we open this up, we'll see the challenges along the way, but the idea is to keep pursuing and persevere. There are answers at the end of this rainbow, and hopefully, like our experts here on the panel, they'll be leading the charge in terms of identifying those patients and helping them. So it's very important for all of us to keep open to the idea of treatment, to learn about the advances, and to work with our colleagues in these fields that are leading the way.
Great. Thank you. Dr. Rosenblum?
Yes, so I want to refer back to something you said earlier at the beginning of the presentation about the number of patients who are missed who have mild cognitive impairment. And there are many reasons to make an early diagnosis of MCI or dementia. And now that we have novel treatments, it's another reason that we can add to that fairly long list. And we'd like to see a future where we can leverage biomarkers that are accessible to clinicians, whether they're primary care or specialists, working in rural versus urban populations, so that we can identify those patients who will benefit most from interventions, whether they be pharmacological or non-pharmacological. There's a lot of work that needs to be done.
Great. Near and dear to my heart. Dr. Gaster.
Yeah, and I would just say we are entering a new era in which, as I do my work going and talking to primary care doctors, they want to do a better job with this disease. I think that the years of nihilism are past us, and the time to really embrace our values, which are meeting patients where they are and helping patients with the difficulties that they're experiencing, now includes cognitive impairment, and that there is just really making the case that there's just so much that we can do to improve people's brain health, that primary care, these are things that primary care is already good at, helping people with their hearing loss, helping people with their sleep apnea, really paying close attention to the potentially harmful medications that they are taking, their alcohol use. Those are all things that primary care wants to embrace and wants to do a better job with. And so I think really the time is now that I'm meeting primary care doctors who are say oh my goodness, there are things that I can do and I want to be doing those things. And that primary care is an eager participant as long as they have the right education and tools to make it happen.
Great. Thank you. Thank you all. Just GSA wants to once again thank ASI for their generous support of this momentum discussion. And we hope all of our viewers enjoyed this webinar and you found it both informative and enjoyable. Thank you very much. Have a great afternoon.
Check out GSA Enrich at gsaenrich.geron.org, which is your gateway to a library of engaging learning resources. Access toolkits, courses, webinars, and more podcasts, all tailored to support your interest and advancement in the field of aging.